Have you ever wondered how it all works in our health system? Have you ever been curious about how funding is distributed and what the priorities are of our healthcare system? Well, today we are talking to Dr. Devin Harris. He wears many hats and he helps us unpack some of these questions that all of us have about the delivery of healthcare, the quality of the healthcare that we're receiving, and why it's so important that patients like you and I have a voice. Today on the Wealthy Podcast, I am very pleased to welcome Dr. Devin Harris. After 13 years at St. Paul's Hospital in Vancouver, Dr. Harris, who is originally from Penticton, answered the call to come home to the Okanagan and KGH in 2014. Dr. Harris served as the department head and medical director of emergency at KGH starting in 2015, and later he became the chief of staff in 2017. Then in 2018, he was appointed to the position he continues to hold today as the executive medical director for quality and patient safety for Interior Health, which is a very long title, and we're going to unpack that. But what you do need to know about Dr. Harris and why we're so grateful to have him on the podcast is that since arriving at KGH, in addition to research and academic and clinical work, Dr. Harris has been a tireless advocate for patients like you and me who live in the interior of BC, which is ultimately how we've come to know Devin. Can I call you Devin?
Please. I was going to correct you on it anyway.
Okay, I know. Well, I start formal and then I just get progressively less formal.
Perfect.
Yeah, so that's how we've come to know Devin so well. When he first arrived at KGH, he marched his way over to our offices and introduced himself. And now, today, he is the co-chair of our campaign cabinet for our most ambitious fundraising campaign ever, $40 million. But this isn't the only campaign that we've worked with Devin on. There have been many. And he's so great because he is able to connect the dots between the challenges that we're facing in healthcare, and in particular in the interior, and the incredible work that's being done on the ground. And I think sometimes those stories get lost, certainly recently, last few years. So that's part of the reason why we're doing this, is to sort of pull back the curtain and start to tell those really inspiring stories of what's actually happening in healthcare. So that was a super long intro, but I feel like you deserve it. But welcome, Devin.
Shauna, thanks for having me.
It's a pleasure. So I'm going to start with we have this like opening tradition on the podcast, because most of the people that are sitting in that chair come to the conversation having a background and an interest in health. And so I'm curious, where did that start for you? Do you have what was sort of the first time that health or healthcare ever really sort of became like a conscious thought for you?
So first of all, thank you again for having me today. So, and do call me Devin, thanks. Okay. So my background starts probably in healthcare because my dad was a physician. So growing up, what I remember when he was a full service family doctor in Penticton is the stories that he might say, or when he would come back late, or when he wasn't there. And then the kind of key memories started when he went back and retrained as a dermatologist or a skin doctor. So I distinctly remember having to move to Minnesota, of all places, and live there for 4 years, which was the formative years of both my language development. So sometimes people say I have a Midwest twang, which is interesting, which I don't think I do. But I just remember healthcare being a key part of our family because that's what my dad did. And so around his work, around his clinic, and I got to visit him and see it when I was there, that was just who we identified in terms of healthcare. In a small town, Penticton, when I would play, say, sports on a hockey team, people would know him just based on who he was. And so it was just really interesting to see the community and how he was reflected with the community and just his relationship with them, because he's a fantastic guy and he just was really part of the community and just showed it in the way that he was just who he was. From a a personal perspective, I mean, everyone gets stitches at some point, so I remember that. I've had my own healthcare experiences as well. The more you get, the older you get, but have been fortunate as well to receive great care here in Kelowna. And then as with all of us, I mean, we've been through birth, we've been through death, we've been through mental health, we've been through other care as well. So when I see it and experience it, you really do see what it's like to be on the other side. Most recently for me is getting a CT scan. And when you sit there and it's quiet and you're by yourself and you're in a room and thinking about that, it is a way different experience than if I'm an emergency physician ordering a CT for someone to go down the hall and get it done. So it gives you perspective as well. My sister-in-law had a stroke at a very young age. So that was partially probably what got me into the direction of stroke care, stroke research, and otherwise, which I'm sure we'll get to at some point in this podcast as well. So pretty much everywhere, family life, work life, professional life, it's kind of been around me and part of me, as it is for everyone ultimately.
Yeah, and I love the reference to just kind of the being a patient, because I also had my own healthcare journey a couple of years ago, and it really changed my perspective a little bit when I became a patient. We talk about patient care and healthcare and the delivery of healthcare, and in your case, the quality of healthcare. But then when you actually become a patient, and in those quiet moments when you're waiting, just like everybody else, and the thoughts that are going through your head, having that awareness, I think for me, and I imagine for you as well, can really cultivate that sense of a much needed sort of empathy and compassion. And I think that's one of the things that what I really love about you and what sets you apart is that you have never, like, that part of you is never really separate from the, emergency physician and now your leadership role. So thank you for sharing that. And I think that that's something that we need to celebrate, is that. That's
very kind. Thank you.
Yeah. Okay. So I rattled off your title. I'm going to make you say it again.
It's different now.
I know. Actually, it's funny. I was reading it. I'm like, I actually feel like it's changed. And then I want you to unpack it. Like, what exactly do you do?
So the interior health title is Executive Medical Director, Quality Engagement and Research. See, I even stumbled over
is it
trying
right?
to say it.
Yeah.
So Quality Engagement and Research. So, but I have other roles. So I still am an emergency physician, infrequently, but work clinically here. I'm a transport physician, so I work for the BC Emergency Health Services, or the ambulance services, and this is for deciding inter-facility transport and providing support for paramedics. So when someone's critically ill or needs to move from one site to another, we help coordinate that and provide support to paramedics, or paramedics on call at bedside, roadside, wherever. We provide clinical oversight and provide support for them there as well. And then, so provincially as well, I'm a chair of an organization called Health Quality BC, which we'll probably get to at some point. But for the Health Authority, the role that I have is around the aspects of quality and patient safety. So the delivery of high quality patient care can be looked at in what's called a health quality matrix, or things very specifically around how good is your care, what's the experience of your care, how well we do in terms of financial stewardship, and then the provider aspect of care as well. And there's pieces around quality of care that we need to ensure, standards of care, credentialing and privileging, but there's also pieces around what's your experience like when you're in an emergency department? Were there navigators for you and how you accessed care in emergency as well? Do you know where your care concerns apply? So I have a role regionally on the quality side. On the safety side, when an event occurs or a harm event occurs, or on being able to protect from harm, such as surgical checklists or otherwise, I'm involved with that. And then the engagement aspect is really around the workforce. So we don't have high quality, safe patient care if our workforce isn't feeling like they're part of the team, they're engaged, they feel well, they're healthy as well. And so that part on the medical staff side, so physicians, dentists, midwives, and nurse practitioners, that's what I'm involved with as well. And then the final kind of key piece is around research. It's where I started. I have a background in it, and then I have a research leadership role for the Health Authority. In any kind of learning health system, you want to be able to look at what you're doing, research what you're doing, and put it into practice right away. So the continuum is almost kind of fits. Doesn't make sense in terms of a title and it's long, but in terms of being able to use all these things to improve care and move forward, it makes sense for sure.
And I get that, because ultimately your concern is the patient's experience, right? So, and there are so many different things that will impact that, right? And then it's also translation, like when you do learn more about the patient experience and what we can do to perhaps, change processes or shift how we deliver care, the research component of that. And I know your research has been quite specific in the past. Mm-hmm. But I want to circle back to how do you...
If I can interrupt for a second.
Yeah.
We used to focus on, not focus on experience. So we used to more focus on outcomes. So we would more focus on clinical care delivery and how best to operate, take out cancer, provide best quality care as delivered by doctors and nurses. We would be telling patients what we thought was best for them to deliver care upon them. But patient experience now is actually where we now have a focus. So before it used to be on clinical delivery, because we still want fantastic outcomes. We want to screen and treat and do things appropriately, but we forgot about the experience part as a key part of health and a journey back to health. And even in wellness, an aspect of wellness as well. So all of that around what your experience is with care, the screening care, delivery of care, even backing up to how you have kids and how you're supported as a mom is critically important for us downstream and to sort out in terms of healthcare. So experience now is very important versus where it was potentially in the past where it was less important.
That's so interesting, because I actually think you're right in terms of perhaps maybe I would say back in the day, right? Maybe when your father was practicing in Penticton, there was that connection between patient experience and the work, right? Yep. But then, as you say, you said something, financial stewardship. I'm curious about that. But as healthcare has gotten more complicated and funding has become more complicated, you're right, the focus shifted somewhere along the way to efficiency and outcomes and all these data points and metrics. And then the actual interface with the patient is sort of lost in all of that, because you just sort of assume, well, if there was a positive outcome, then it must have been great. Yep.
If you're cured, it was good.
Right.
Yeah.
So when did this start? Like this shift in thinking start?
So, I mean, decades, and I can't say we're broadly generalizing in terms of totally. What was the focus, but I think the part around it that's really become evident in healthcare is there's a tagline that says people don't remember what you did to them, they remember how you were to them. And so it became very clear to me as well as an emergency physician, we don't have much time to have an impact on people's lives. It is very brief, it's very short because we have to be. But if you can make those very brief moments very meaningful in the time that you have, that's the part that people do remember in how it goes forward. And what's become really evident is relational. So health really is relational. You are well or not, but our ability to improve health is how people around you, how your interaction with the system, how your interaction with care providers really can help you as well. So we now have really huge pieces of work around what the experience is in care, to measure it, to have outcomes around it, to focus our care around it. And that's why now within healthcare, you design healthcare with patients and partners as part of your design to say what really is important to them in the building of something, in the doing of something, in the delivery of something. So for so long, we didn't know what was told to us by care providers in terms of our health. We didn't know what the lab test meant. And you're right, because healthcare is so incredibly complex now, it does need ability to translate and support for it right now within healthcare. Mm.
Well, and certainly that's a story that we're not hearing in our mainstream media reports, which is unfortunate, that there is dedicated people like you and resources to try to be better, try to facilitate those relational or soft skills that really help. An outcome is one thing, but the experience of a patient, and we see this, it's funny, I am on various social media, community groups or whatever, and I am always delighted when I see, and they're always like this. I'm not even hyperbolizing, like the positive experiences that people have at KGH. Somebody will say, I'm part of this group, it's a rant and rave, and so people will be like, oh, this was awful, or this was great. Always for KGH, I had amazing care. Say what you want about the system and all the things that, may need to be addressed, but the care that I received from the people was amazing.
Yeah, and it's I have great faith and optimism around that as well, because although we're talking about it in a way like this, people get it and they understand it. Mm-hmm. So our chief of staff recently was a secret shopper through the emergency department and had similar accolades, saying, I didn't say who I was, I didn't acknowledge it, but people treated us incredibly well, and it was great care. So thank you. So
that's interesting. You secret shop yourselves.
I never mention who I am until people recognize me.
Interesting.
Yep.
Wow.
Yep.
Well, that's great. I think the community would be happy to hear that, because we all have, let's say in private business, this is a thing. You want to have an understanding of what the basic experience is for people, right?
Yep.
So,
yep.
How did you end up here? You've sort of explained that you were inspired by your father and his journey, but how did you end up sort of moving and choosing emergency medicine, and then now you've sort of transitioned into more of a leadership role and taking on this quality mandate? Mm-hmm. How did that all transpire? Tell me about young Devin.
That's funny. Young Devin, I'm gonna have to go way back now for that.
Stop.
I think so. The progression into medicine was probably one that I had thought about, just having exposure to it with my dad, and it was an interest. So that's probably the direction that I went into at first. I actually was not interested in emergency at first. So I went down the path of being a general surgeon, and specifically a pediatric general surgeon. So this was training through medical school, research that I did, rotations, which means when you go through your medical school, you choose what you want to do as extra electives. And so I did that in pediatric general surgery and got reference letters and applied and got in. And then when I was in and started in the path of working within general surgery and working with, not with kids at first, because you do general surgery training on adults and across, I realized, this part of the medicine, I like the upfront stuff. I like the acute care things, like the initial visit. And then once I head into the operating room, kind of feels like I'm missing out on what's going on in the acute care.
They're
early
sleeping.
stuff.
You can't talk to them.
That's right. There's music playing. You're doing some stuff when you're in the operating room. And so that's when I transferred into emergency. And so when I transferred into it, I just stuck. So I was trained at St. Paul's in Vancouver, and the group there at the time was unbelievable. They're just great people and a great culture, and just a fantastic group from whom to learn and work. And so that's the direction I started working in Emerge at St. Paul's. My shift into leadership, all of it, when you look at in hindsight, is kind of meandering and accidental, but with kind of choosing little pieces of opportunity. So I can't say it was ever mapped out in terms of where I ended up, but it was more probably interest, excitement, and aptitude around things. So got into research, moved into a leadership and quality role for improvement. And then what I found in the role is that there's opportunity, and specifically for physicians in leadership roles. So to be in a clinical care environment, to have understandings of various aspects for health leadership, and really to be able to step into that was the part that I took for the various things. So I can't say it was totally mapped out, but the other part probably is, I have a little bit of attention deficit. So you get interested in one thing and move to something else, and it just fills your bucket when you're there. And so that's why I'll do it as well.
So we can expect more shifts to come.
Absolutely. Absolutely. There's lots of work to do, and there's lots of opportunities. So it's just fun to be part of it, especially now.
Yeah, it's funny because we've spoken to a number of physicians now, and you're not the only one that changed their minds sort of like as you were on the path in terms of where you wanted to specialize. So I'm going to circle back though, because you've referenced clinical care a couple of times. And I think this is one of those buzzwords, clinical, that we use in sort of like the health community a lot. But I don't know if the general public really knows what we mean when we say clinical care.
So what I use it for is the delivery of care. So the services that are provided wherever they are. So it means in the community with your family doctor, in a community health center. It means an emergency department or what you get in acute care as well. So it's around the healthcare service delivery that one receives.
I see. Yeah. Okay. So then are clinicians solely physicians, or can they be others?
Yeah, absolutely. So, and I mean, this is the big question, and what the transitions are in healthcare is us moving away from an acute episodic model of care. So hospital-based, disease-based acute care, which, hasn't solved our healthcare issues, but a more holistic view of health as not just absence of disease, but in a positive light of all aspects of positive healthcare. And so some jurisdictions and countries have called it now health and social care. So that's the department. It's not a Ministry of Healthcare, it's a Ministry of Health and Social Care. Or others have looked at it in terms of health in all portfolios. So there's an aspect of health in education, in development, in business, in finance, in social care as well. And so when you look at it, support in terms of housing, in terms of income support, in terms of support for children and families, maternal care, maternity care, this is a foundation of society. Built environments, how we build our environments, and cycling paths and considerations with the city as well. This is a determination, force function of how we look at health. And so now that's the shift that's gone, a way of saying it, an acute episodic definition specifically. And now everyone really is involved in delivery of care, like educators and teachers involved in mental health for kids and supportive environments, anti-racism, anti-bullying. That's a part of healthcare, and determination of it as well. So the way I look at it is that, I might have a specific key focus in delivery of care that's trained to do that, but in partnership with many and all, everyone has a skill set that can be able to be provided for a provision of care and provide health and wellness for society overall.
Well, that's a really good pitch for this podcast.
Not a plant. It was not a plant.
It was not. I didn't make him say all that, but I love that you have articulated that, because that's ultimately why we wanted to do this podcast, because while the KGH Foundation works in very close partnership with the Health Authority and other partners that are responsible for the delivery of healthcare, what we're coming to understand is that it's vast. It's so much more than just acute care, as you say, disease or injury.
Look, we talked about before, I'm not a marketer. I'm not perfect with it. I'm not businessman. Parts of it I have, but they're, financial accountants, engineers, human factors engineers. We can learn from all of it and what can be done as well. Mm-hmm. But the other part is actually a societal shift. I think Canadians, interestingly, historically expected healthcare to be delivered upon them. And expected the decisions that were made by their doctors, pharmacists, nurses, other healthcare leaders, and what they said they'd follow. And it's a demographic shift is one, but it's also one in which I think Canadians can be more involved. And so I think we as Canadians and society can't expect healthcare to do everything for us all the time. Mm-hmm. So we have to take ownership over our own health and how we are able to impact it, but also really to step into leadership and changes in health which are needed.
I absolutely love that perspective. And it's interesting coming from you, because you're so deeply embedded in kind of the infrastructure of the existing system, right? But part of what we're really hoping to cultivate through these conversations is this notion that that it's our responsibility as human beings, that our health, that there is an opportunity for us to participate in our own healthcare.
Completely agree.
right?
Yeah.
And so it's really refreshing to hear you say that, because I think that having that awareness certainly, and tell me I'm wrong, but would influence how you move through your work and your job and your understanding of what your contribution is going to be.
Yeah.
Does that make sense?
Totally. And I think as a receiver of healthcare, when I go through Emerge with my daughter to get tested, I can think of things that can be done better for kids. And you walk away thinking, oh, I wish I could be able to do something about it. So you feel more like you're on an outsider as a public member to be able to shift and help with healthcare. But part of it's also the consent to change and be involved. So I think healthcare now is giving consent to society and patients, families, communities to be involved. And so now there's accountability for us on the healthcare side. We can't own all of it. And so that's where partnership to understand where the gaps are is really where the next opportunity comes to improve care.
Mm-hmm. Love it. And as you said, healthcare is complicated. And so the more that we can do to just educate ourselves, before I was diagnosed with cancer, it didn't matter to me. But then as soon as you get that diagnosis, all of a sudden it's like, wow, how can I take an active role going forward in my own health and recovery, and making, there's lots of information out there now, right? We're not the only podcast out there talking about healthcare, but there's lots of information out there that people can use to empower themselves, to learn more about what they can do, whether it's, diet, lifestyle, sleep, all of those things to impact their overall health.
Yeah. Agreed. Yeah.
So cool. Okay, now I'm going to get into the maybe a little bit sweatier conversation. Because since I have you here, and I know that I was trying to think about, what would people want to know from you, knowing that you're sort of on the inside of the system. Mm-hmm. And there's not a lot of opportunity for us, just sort of regular people, to see know what's going on inside the system. So how would you, we all know it's been difficult, especially the last couple of years, but we know that the problems that we're sort of grappling with have been simmering for some time. But how would you characterize kind of like the state of the nation when it comes to our system of care in Canada, and then maybe more specifically here in the interior? How would you characterize that post-pandemic?
I think probably people wouldn't be surprised if I said it was challenged and challenging. I think that it is more complex now as well in terms of delivery of healthcare, funding, leadership, decision-making, probably than it ever has been. So I think the challenged part is around we knew that, first of all, around the people, so the human resources or the workforce, so the number of doctors, nurses, lab technicians, physiotherapists, all of our staff, how many we have, and we knew there's a bubble in the workforce. And so what the pandemic did is ushered many in the workforce into retirement. And so we knew that there might have been a gradual decrease in the numbers of people working, but post-pandemic, people just decided that this was a natural time for them to retire. So the workforce crisis and the vacancy was exacerbated by the pandemic. So that's the first. The second is around the complexity of the healthcare system. So probably because of our knowledge around diseases and best practice and our understandings of it, we need subspecialized care. Before, it could be provided by a generalist in a generalist area, but now there's really complexity around care delivery for babies, complexity around care delivery for kids, and obviously in chronic disease and cancer as well. So you need people with specialized knowledge and care to do so. It requires training for a long time for them, but it requires really clear pathways and abilities to navigate the system to do it as well. That's very complex. Mm-hmm. Aging population puts a strain on the healthcare system. So as we get older, we're straining. But along those lines now is within the interior specifically, we've had incredible growth. Like there's 250,000 people in the central Okanagan, I think, in catchment now, and it's one of the fastest growing municipalities in the country. And so we, at Kelowna General Hospital specifically, have had to deal with this incredible growth along with being able to provide subspecialty complex care closer to home. So I think as far as healthcare, the final thing around challenge is it's transition. So we're in transition. So right now, what we learned during the pandemic is we can pivot very quickly. So what we thought we couldn't do, like virtual health, we could do pretty much overnight. And so now we, within the system of, legal systems, electronic medical records and transfer information, we've had to learn how to adapt and put them in place in a thoughtful way that's safe from a privacy perspective, safe. But in doing so, we're now trying to realize and put in these innovative practices as well versus how it was done before. I think also what's really big and changed now in terms of healthcare that's challenged is nothing can be provided individually. So I don't work individually anymore as a physician in the emergency department. I never really did. I always worked in teams. But teams now really are what needed in terms of mental health and addiction, raising kids and childcare, maternity care, and then primary and community care, which is probably one of the biggest gaps in Canadian healthcare, is to have a really robust community and primary healthcare system, which is and can be and should be provided in teams. Not everything needs a physician to be seen when you need healthcare in the community. And there's great models being proposed around what's called a patient medical home, where you, like a catchment in a school, you would have a catchment in your primary medical home where you'd have access to a physician, a pharmacist, a social worker, a physiotherapist, otherwise, just as you would do if your kids were going to that catchment as well. So there's a lot of new design, redesign, transitional things in healthcare, and under those, it is being challenged because of us having to keep the lights on and provide surgery and provide care when we're going through these transitions as well.
And certainly, I mean, just any one of those things that you've mentioned would put strain or pressure on the system. Just the HR challenge.
Oh, it did. Yeah.
And I think
it does, and it still is.
And it still does. Yeah. And I don't know how much people realize how big of an impact just that has on our ability to deliver healthcare. Right. I do love what you're saying. Just with regards to that, there are opportunities for us to consider other ways. I think that it's really important that our community hears that there's hope.
Absolutely.
Yeah, and that's kind of one of the things that keeps the foundation going.
Yep.
Right? Is that our currency is hope. Because if you don't have that, what's the point?
Yep.
So can you help us understand how funding works in Canada in terms of the funding comes from the feds and then it goes to the provinces and then there's health authorities and then all of a sudden we're funding this project and not that project. Like, how does that all work?
So I don't think anyone completely can explain it truthfully. and the reason being is because there are various and multiple streams that provide funding for healthcare. So it isn't as simple as a media headline where one group blames the other for not funding a piece to it as well.
Right.
Or lays accountability on one for low funding or otherwise. Broadly, the federal government provides transfer funding to the provinces for healthcare delivery. When that transfer funding goes to the provinces, it goes to their general budget though. So the provinces can decide internally how much they allocate to healthcare and to what they allocate to healthcare and prioritize. Suffice to say that healthcare is the largest expenditure for the province. So it's over 50% of all budget spend from provincial government is toward healthcare. And the federal government has jurisdiction around specific areas of delivery of care. So veterans and the RCMP and the military specifically, they provide specific care, but the rest of it is allocated to the provinces to provide care. The provinces then will decide where and how they fund. So a Ministry of Health and the Ministry of Mental Health and Addictions, but keeping in mind that, other ministries do have pieces of budget that are specifically targeted for healthcare that overlap, will decide where that funding is allocated. So to Interior Health, it's a significant amount of money that comes here. And I have to look down to get the number exactly, but it was $3.6 billion in 2023. And that's to interior health. And we have just over 840,000 people in interior health within a province that's over, close to 6 or 7 million now. So we're not as much. But the money, how it gets spent when it's decided is even more complex once it's within a health authority. So we have to fund everything from long-term care homes, community-based nurses and community-based care providers, social workers in the community, CT scanners, new hospital builds, traffic, parking and security for our hospitals, food services. I mean, the list goes on. The largest, within it is probably compensation for the workforce and staffing. But within that as well, there's various layers and types of staff and the staffing that's included as well. I'm not even including the where and how other funding sources can come in. So in innovation and industry, municipalities, academic organizations, other government agencies provide it in terms of funding. The foundation very clearly didn't leave you out specifically, but to say that it's a big player in how things are decided. And so there is always an opportunity to fund healthcare, and it is and will be a substantial drain on provincial resources. But that said, the solutions don't come from just putting more money into the system.
Right.
And that's where now, in partnership, we're looking at ways, the collective we, all of us, that we can improve healthcare, but not in a way that has to keep spending so much more on healthcare from a provincial standpoint.
Are you able to, I'm springing this on you, so if you don't have an answer on the top of your head, that's totally fine. But are you able to provide an example of that? Like, so where we're trying to come up with other solutions that are not anchored in just getting more money to improve healthcare? Yeah,
so it's around, so what some literature has said is around what we do in healthcare overall, it can be determined whether or not it has added value. So wait times, for example, in healthcare is not added value. There's specific things where you should have a wait time to allow whether or not a disease will declare itself or not or get better. So waiting to see a specialist or waiting for surgery. But wait times in general to get something is considered waste. There are certain tests and procedures that don't need to be done, also considered waste. There are efficiencies in care delivery. So say, for example, that you have a day procedure that needs to have done in the operating room. When you think of it, you'll probably go through the path of seeing a primary care provider, getting referred off to pre-surgical screening or a clinic, getting seen there, getting lab tests done, going back to see your primary care provider, then maybe back to the pre-surgical screening to get booked for a day. And so there's pieces in the patient care journey that can be made a lot more efficient, where we can reduce the waste of both patient time, off work travel, being away, getting testing, lab testing. So it can be done in a lump, co-visits at the same time. So you see your specialist, your surgeon, and the person who puts a cast on at the same time. Very efficient, saves time with it as well. So that when we think of care redesign or delivery and the efficiencies without having to put more money into it, there is a lot that we can do in healthcare that would be able to do that.
And so that is part of where some of those efforts are being focused. It's rather than just being like, oh, we need more money for this or more money for that. It's like, how can we look at the system, redesign the system so that it actually works better for patients, but also works better for our primary funders, which are taxpayers.
Exactly. And if you think of it, that's where there's shared ownership. It is always cheaper to prevent something than to treat it. And so if we move everything to the, let's call it left shift or upstream or early on to try and prevent screening, moms and families, support for patients and families in that way, great primary care, good comprehensive primary care that does prevention, then you don't get down to the acute care, high costs of acute care and episodic care.
I love that you've included prevention in primary care. How does that, again, this is not a question I'd planned to ask, but since the conversation's going there, and I do think it's something that people are curious about. Like, there's all these sort of different modalities of healthcare, right? We've sort of compartmentalized them into, well, maybe not everybody has, but I have in my head. Acute care, right? Which is the stuff that happens in hospitals,
yeah.
right? And then you have like the upstream stuff, right? So the health, maybe prevention programs that help catch some of these things so that people don't end up in hospital. And then you have the promotion side of things, that modality where, let's say you have a nutritionist, or you have like a personal trainer, or you got a gym membership or something like that, so that you can stay healthy. So again, you don't end up being in the hospital. I think one of the biggest criticisms that is being perpetuated in our mainstream media is that this lens of health promotion isn't necessarily integrated with primary care. What would you say to that?
I mean, yes and no. So I think the part that we're also aware of in healthcare is with social media, with online platforms, and really what came to light in COVID is there really is an explosion of misinformation. And so I'm involved with a group as well, a foundation called Clarity Foundation, which is looking to combat misinformation and really provide trusted viewpoints and opinions from medical experts. I can understand where it comes from, because the pandemic, people lost trust in the system, or they didn't know who to trust. And so now it's the part around rebuilding trust. So that's the first around health promotion. There'll always be snake oil salesmen and others who want to make money off whatever.
Totally.
But the piece around it, I'd say that primary care really is the foundation for care. And it's not necessarily owned particularly by healthcare. So I think, having a good foundation of primary care, and health promotion is going for a walk, or getting out in nature, or eating properly, not drinking too much or smoking. Like, all of these things aren't things that the healthcare system can do on someone. It's something that's owned, and individual accountability. So I think how you go about that in an environment, and where and how it is part of health and wellness, is critically important. Cultural practices, like, incredibly important. Nutrition around cultural practices are really a foundation for keeping you out of hospital and being unwell as well. So I think that the splitting that's occurred in determination of healthcare, we have to do it for funding and buckets of funding, but really as an individual or patient, it's one big continuum. It's part of everything of what you do in care.
At the very least, I'm so happy that the conversation now is definitely inclusive of not just acute care. Like, we always used to think healthcare is hospital care.
Hospitals, your family doctor's office.
Yeah, totally. Yeah. And I do think that one of the benefits maybe of all of the information and the new channels that have been expanding in terms of how we tell stories and get information out to communities, that the benefit that is that we're starting to include these conversations about health promotion, prevention as part of a health conversation.
Yeah. And as you would know, like, we healthcare leadership don't decide that. No. Like, right now it's really granular, and just it's social media, and it's organic.
Yeah.
And so we just shepherd the conversations around it.
I love that.
Which is weird coming from an emergency physician, because mine is acute episodic care when I provide clinical care. But if you do need it, if you get in a car accident, or if you have a heart attack, then the system will be there, and that's the part that we should be able to do really well.
I'm going to kind of like distinguish a little bit about what is unique about the delivery of healthcare in the interior of BC. Because this is an important distinction, I think, that people need to understand, that I think we're special here in the interior.
So do I. That's why I came here.
Yeah, exactly. So what's different about the delivery of care from your perspective, working in leadership within the system? What's different about delivering healthcare in the interior as opposed to some of the major urban centers that you've worked previously, like Vancouver or Toronto? What is different about the delivery of care here?
It's interesting it's shifting now, but when they used to train us as physicians, we would always be in the Torontos or the Vancouvers. And so we would get a very skewed view on what healthcare is, or what's needed for healthcare. So it was very subspecialty care, urban focused. very specific and very, didn't really consider the aspects of what's here in the interior. So I remember working at St. Paul's, and we would get transfers into St. Paul's from throughout the province for complex cardiac care or kidney care as well. And it would be transferred in. And when I would work there, in my mind when I worked, I'd be like, oh, what are they sending us? Like, they don't know what they're doing up there, really. This is true, and how it ends up being trained and ingrained. And so I would see care that would come in from areas, not rural even, like places like Kelowna and Kamloops. And I'd think, oh, they need our help to be able to sort this out. Mm-hmm. And so it wasn't really like, even growing up in Penticton, like that just felt like who I was when I was there. But then as you go through training, which is being changed in medicine now so that they train us in places to understand this, it was not until I came back to Kelowna where I really understood what rural and community healthcare is. So how we're very unique and distinct is we have huge distances between cities, number one. Number two is Interior Health has the most number of acute hospitals. So we have 22 hospitals. We have a substantial number of community health centers, all separated by roads and winter. And so the ability to deliver care is challenged based on that. The second is at Kelowna General Hospital, when I first came here and then I was chief of staff, I got a tour of the operating rooms and the whole operating suites. And they're fantastic and unbelievable. And I think largely thanks to the benefit of the foundation and people who work with the foundation. So I want to say thanks.
For that.
I want to say thanks. But the people who work there are spectacular. Like, I found out not from them saying how great they are, but from colleagues in other sites, that the surgeons here are top notch, like some of the best trained surgeons in the country, but who decided to come here because of what this place offers. The difference is they don't have layers of trainees. So they don't have residents, fellows, and other trainees and house staff who normally would do a lot of their work, which is part of training. Go to the emergency department, take call, see all this stuff. So these people are not only operating, but they're also doing all their own call regionally as well. So they're very, very busy. Yeah. Complex care. And it is complex care that's provided here as well, which is different. The other kind of major piece around this is our Indigenous communities. So we have multiple, 10 to 15% of our population is Indigenous. We have multiple Indigenous communities that are very different. And so how we deliver care and how we interact and how we partner to provide wellness and support for is very important in the interior, which is different, again, than the Lower Mainland. I think, though, and the reason why I came here is this is the newest kind of academic health sciences center in Canada. So we are actually building up in partnership with UBCO and the university and the medical program to have research, training, people, innovation, aspects of care and partnership that nowhere else in Canada is doing. And we can actually kind of build it as we want and do it the right way as we're doing it here. So it's almost entrepreneurial in being able to redesign and partner in the development of healthcare. And that's how I think we're actually different. Mm-hmm. So I'm starting to see a lot of like-minded people come here, not only because of the hills and the nature and the community and the fact that our kids go to the same school and all that stuff, but it's also just because of the opportunity to do things in an innovative way that you don't get in a tertiary quaternary healthcare center. There's layers of people and institutes and governance and roles and the rest of it, whereas here you can actually work directly with patients and families, and you can do things in partnership to be able to build healthcare. So I think that's how we're different.
And that's certainly, we talk about hope and kind of how we unravel this giant ball of yarn that we are faced with right now in healthcare. And I agree with you. I mean, we are so fortunate here at the foundation because we get to, stick our little baby toe in these things and have a part to play. And it's been really exciting. And it's part of the reason why I get so excited to have people like you come and talk about this stuff, because again, I just feel like these stories aren't being told. And now we have the opportunity to talk about the good stories, the good things that are happening. So tell me a little bit about, you sort of shared about the research component and the partnership with the university. Would you say that ability to kind of do our own thing here in the interior is one of our strengths? Are there other strengths that you find that we have here, sort of, again, that set us apart from everybody? Sort of puts, I shouldn't say everybody, but the delivery of healthcare in urban centers like Vancouver and Toronto are sort of put on a pedestal. And we do that too. Even the foundations that are in those serving those hospitals are like, the gold standard for us, right? But like, what are our strengths here in the interior?
Yeah, I mean, it is very noticeable what is provided in terms of care from a rural standpoint. So being a transport physician and hearing what's going on in rural areas and the care that's provided by doctors, nurses, and other staff in rural areas, it is unbelievably high quality care. So I think we also will say, oh, it could be better, we should do better, and we have to do better. But for people I know who go on global health and go on missions and they provide care in other areas, we're pretty darn privileged in Canada, first of all, and in the interior, second of all. So I think as we have an opportunity to reflect in where we go to from now, I think we start that from a position of gratitude, and what we have is quite a lot, which is fantastic. I think that the part that's noticeable is, in my view, is the staff is one. And what's really noticeable about the staff is they came here for a reason. They came here not because they wanted to be in a larger center for multiple different reasons, but in doing so, that's their purposes in being connected to community. So they're excellent people, excellent physicians I'll speak to, and nurses, but they're also connected as well to the communities also. And I think that's a major, major strength here.
And I have heard this from other physicians, but is KGH and the kind of care that you're talking about setting a gold standard for other rural or interior-based rural regional health centers, in Canada or around the world?
Yeah, specifically. So I can honestly say that the growth of the cardiac program, the growth of the stroke program, and the growth of the trauma program, to name a few, have really been thoughtful in terms of how you support rural practitioners and people who need those services and be able to provide best quality, high quality care. So I previously was medical director provincially for stroke, and the interior needed a fair bit of work to bring up to some standards. This is back in 2010 and a bit earlier. This year, the interior won an award from the Provincial Health Services Authority for their stroke program as leading practices in stroke. And it shows in their outcomes. So what happens now with partnership from fantastic leaders, innovative people in the foundation as well, is the stroke program now is able to, like, if you have a stroke in Williams Lake, if you have it in Penticton, you have it in Fernie, we're able to, within the stroke care system, be able to provide high quality care. And that's different. And so I think what Kelowna is doing is being the fact that we're able to build up and go from, a community hospital, so to speak, to now being an academic health sciences center that has clinical care, teaching, and research as part of its core kind of mandates. We're really showing that we can do it in a thoughtful way that has equitable care. So it's not, building up an ivory tower in a center that doesn't care what's around it. We're actually doing it in a way that thinks about how KGH serves the community and really the North now, because KGH does a lot to serve the North as well.
Yeah, and it is different here. I totally appreciate what you're saying, that the challenges that we're facing in the interior are different. And I am so proud of the work that's being done here in Kelowna at KGH to look at these challenges from the lens of the people who live here. And I know you talk a lot about that, right? That's so, so important. We can't just port the same, even though they're world class, the same solutions from urban centers to our community, because it doesn't work.
No, and it has to be tailored for drive times, for the people that are there, virtual support, ability to get other care as well. And we're getting there, but we're doing a great job for some things, definitely. Yeah.
Okay, so this conversation is flying by, and there's a couple of things I do want to ask you about, because I know you're really passionate about the research stuff.
Yep.
So tell me about the research that you're engaged with or have been in the past, and what excites you about that.
So I think what when you say research, first of all, even to public members or even to the healthcare workforce, it seems scary and distant and ivory tower. Mm-hmm. So that's the first. So research is and can be accessible. So essentially, it's anything under looking at what you're doing in healthcare and looking to improve it, to see if there's a drug or an investigation or a tool or how you redesign care to improve it. So there's clinical research, like clinical trials where a device or a drug can be done, but there's also what's called health systems research, which is improving how you offload paramedics to an emergency department to improve time to give, say, a clot-busting drug for a stroke or a cardiac event. So I started originally out of feeling that there was something more that could be done in emergency medicine for stroke care. And so when I was training in residency, it was new to provide a clot-busting drug called a thrombolytic for stroke, and it wasn't being implemented into emergency departments overall and in a way that could meet what the standards were. So that's originally how I got into it. So it was around health services care that went into delivery of care, and it then moved into improvement work around stroke care. It's broadened now, but what has been done here, which I'm incredibly proud about, is a recent clinical trial around delivery of an investigational medication for stroke, which allows the brain to hold its breath prior to having arteries opened up in a stroke. And a stroke is where an artery gets blocked in the brain and needs very time-sensitive care delivery to be able to open that up. So what this investigational drug did was it allowed the brain to hold its breath in the time that you got to get to hospital to open the artery up.
Wow!
And it was it's a great story. It's developed by a Canadian, a neurosurgeon in Toronto, in his own lab. So it's almost like an insulin story in the fact that it was homegrown. But for Kelowna to be able to be part of this clinical trial, which was delivered in ambulances, was like international and is like at an international stage amongst other trials, another trial involved with it as well. And so for me, and we actually are one of the highest recruiters for some clinical trials. So we get the most number of patients in versus Toronto, Montreal, Vancouver.
Wow.
Because there's no other kind of competing trials when we do them. We have fantastic investigators in a research program. So on a world stage, people will be like, yeah, this was done in New York, Montreal, Toronto, Vancouver, Kelowna, as far as listed in the authorship of it as well. So, for me, from coming from here, where, we didn't have a medical school, there wasn't a university, Kelowna was a community hospital for a town of 50,000 people. Fast forward to now, like, this is immense and very, very exciting. So the part that I think your listeners would want to hear about is it's not inaccessible research. It's not a clinician or trialist like me saying, I want to do this on people. We have countless examples, and you do, of where people say, look, I've had an event in family, or I've had something, and I really want to be able to support research to improve care. How can we do that? And the matchmaking part of finding an expert in clinical trials or in research or clinician, along with families who come forward and say, this is a real key area I want to look into in research, man, it's paid dividends so far. It's been really good.
And it's really exciting, I think, not just for the people that benefit from that research, but I also think, like, I see when you talk about it, or, we've talked to some other physicians about their work, and we've certainly got a great example of what you're talking about in Save BC,
yep.
Right? Which we have a podcast on, which we can link to in our notes. But I see your eyes light up, like, as a person, like when you start to talk about these projects.
Yeah.
What does that do for the morale of physicians to be able to have, eventually, I hope, a research center here in Kelowna?
Yeah. I mean, that's a key part around the workforce right now, right? So you were providing care, but you also want to have the opportunity and chance to improve your care if you want. And so that's where, my eyes light up, because you alluded to already, there's hope, right? And that's the hope of being able to improve things and do things better such that you have a fantastic outcome. And the hope probably also, and the pride, comes from a sense of kind of homegrown pride as well. So I think for the clinicians and physicians, the nurses and others, being involved in the improvement of care and seeing the shared ability to do so with community members and the public, I mean, that's just fantastic. Like, it's just a way that you want to come to work every day and do things.
Yeah.
So
I would be remiss if I didn't, before we wrap up, I'm going to get in trouble from my producers here, but I don't care. I would be remiss if I didn't ask you about your commitment to working with the foundation because it is very real. It's very organic. You've worked with us on a number of campaigns, very much shoulder to shoulder. And it's been a huge asset for us to be able to work with you because of your ability to sort of provide that bridge between, medical leadership and the health authority administration, but also the patients that you serve and donors. You love donors. You've been so generous with your time in working. And when I say donors, I mean pretty much the community, because you also speak publicly for us. Why?
First of all, it fills my bucket. It's fun. And I when you go back to it, I like people. So working with people on the way to do this is just the part that is the most enjoyable. I think that the part that I see is how you define your team and improvement. And you can be really narrow in how you do that, but you can broaden it. And I have a lot to learn from people each time is like when I get a chance to learn from people as well. I think the working with the foundation specifically, when I did come here first as department head and then as chief of staff, I remember marching into the office and talking to the foundation and saying, your next big thing should be stroke care. And so fast forward a number of years later, I think you've raised for stroke care, I think it was $8 million in like 7 months or 8 months.
Yes.
And the impact on innovation and research and the program itself, take credit for the fact that it got an award provincially as being best stroke care. And that came not only foundation, but the families, those with lived experience, and the partners who said, yes, it's important for us too. So it was ability for us to speak the same language around how we do, and then each of us take our own responsibilities to be able to move that forward in the expertise that we have to do it as well. That's why I get involved. But the other is as I alluded to, I see people in the shopping mall, on the soccer pitch. My kids go to the same school. I was born and raised here. So from a sense of pride, that gives me immense pride to be able to do this and do it different than the Lower Mainland, because they think they're the best. They're actually not. So that's why it's a lot more fun to do it here, is because you work in a great place. And we didn't even touch on that, why I came back, but just look around as to why you come back.
Yeah. Like why did you come? We know, but tell me, like, why did you come back?
So my wife is also from Kelowna, and her parents have farmed here for years as well. And so we found ourselves coming back multiple times with our kids, who at the time were 5 and 7, and just said, why can't we give them the lives we had growing up? So that's one of the main reasons was personal, but professional was this, to be able to build something and to be part of it here as well. So never look back.
And we're so grateful you did. And I think that as evidenced by this conversation, you're a busy guy. You've got a lot going on professionally, but you've mentioned you also are a husband and a father. Mm-hmm. And I'm just curious, like, how do you, and I know you're like that's part of who you are. You're quite proud of being a family man, mm-hmm. Like, how do you balance it all?
Depends. Sometimes well, sometimes not well. You'll have to ask people around me about that. But it takes a village, right? Mm-hmm. So in that sense, that's the part to have. So I have, fantastic, my wife's parents are fantastic. My daughter's working there today on the farm, so it's good for her.
That's awesome.
So it is. So it's just, it's been really good. And coming back here has been really good as well. Mm. Yeah.
What would you say, and maybe you've already had this conversation, but if one of your kids who are teenagers said, Dad, I want to get into medicine.
Yeah, go for it. I think, and there was a interesting time where a lot of physician kids were like, not a chance, just based on what they saw their parents did and how their parents were working. And it's a shift now to realize that we have to change how we are trained and how we work, which is a good thing. And so as it goes forward now, there are tons of spots opening up and are open. So anyone who asks me to speak to their kids about healthcare, I'm like, absolutely. Mm. It's a privilege and a calling to be involved in healthcare. It's not a job. It actually is a privilege to be part of care for someone and to interact with them in probably the most important days of their life. So when my kids say that they want to be involved in healthcare, I'm like, go for it. This is really important. Mm. So yeah, I'll help them in any way if they want to do it. If they don't, that's fine too. Yeah.
Well, and I actually, thinking about that question, like, and your answer, like, you didn't even hesitate. You're like, yes. And despite all of the challenges that we're facing in healthcare right now, you would be happy to send your children trudging towards that,
Yeah.
That's a huge endorsement for, I think, the belief and the hope that you have for the future of healthcare, just in general.
Completely. I mean, like look at our kids. They're the ones that are going to take care of us in the future, but they're going to do a great job. So I think that it's going to be different than what was there before, but it'll be one that will be different in a good way. And so that's why I think there's huge hope in delivery of care. Yeah. And if any listeners do have kids who want healthcare, I'd be happy to talk to them about them getting into healthcare, because it is a privilege to do as well.
Yeah. And I love that you say that. I think that's a perfect way to wrap up this awesome conversation. We've really run the gamut. But there's a lot of opportunity for hope and growth and optimism in our healthcare system. And we're so grateful to you and your colleagues who are really champions for that. It's no accident that I've been chasing you around saying, Devin, please come on our podcast. Because I love your perspective.
Yeah, well, it's been a privilege. I think this is really thoughtful, and I really can't thank you enough for allowing the voice of the workforce to be able to speak, and really looking at the positive aspects of care, which are really important. And there's substantial that is positive in care right now. So thank you.
Well, thank you. And I hope to maybe bring you back as a regular contributor. I think that you have a lot to offer in terms of your insight on kind of what's going on the ground in healthcare in our community. But also, again, as I said, there's clearly a desire for you to be relational and to not just sort of be the physician on the end of a healthcare experience, but to really be engaged and involved. Yeah. So thank you.
Be happy to.
Great.
Yeah. Thank you.